Well, here we are. Good afternoon or morning, wherever you happen to be logged in from. I am Dr. Dan Mingle, founder and CEO of Mingle Analytics. I've just finished my trip through the final rule, all 2,400 pages of it, and I'm no worse for the wear, or at least not much. And we are today presenting the agenda here in front of you. Intend to first dispel rumors of the demise of PQRS and meaningful use and of the delay of MIPS MACRA, give you a quick overview of the quality payment program and a favorable comparison to the old programs. I think overall this is a good move forward. It simplifies things. At least in the short run, it reduces the penalty. There's a lot of clash between the old programs, which they've taken out in this new combined program. We'll talk about the year of transition, or what acting administrator Slavitt called the pick your pace. Talk about how it all fits together, and a brief, my idea anyway, of a pathway to success. This will be, when we presented on the proposed rule, we divided the content into 6 webinars, and I think we intend to repeat that with this one being an overview of the whole program. I'm trying to be somewhat superficial, not get into the weeds too much, just give you that general overall view. We'll follow that up with a focus on each of the performance categories. The quality, the cost or resource use, the clinical practice improvement activities, the advancing care information, and then alternative payment models. And that should conclude things and keep us occupied for some time. So let's see, where are we? There we go. So the merit-based incentive payment system and alternative payment models. A final rule is available for review on the 14th of October, published on the 4th of November in the Federal Register. There is a comment period open on the final rule, open through December 19th. I don't expect it's going to make any difference on the rules for 2017, but I think it is good to put comments in. It will prep. There may be some opportunity yet to amend things for 2017, but I think more than anything, it will help to cue different ideas or maybe some adjustments to the new proposed rule. So I would encourage you to make your comments. I'm still concerned about the lack of measures groups for small practices, and I think in the final rule, some of the justification for avoiding it, I think, is an error in analysis of the data. So watch. I'll be posting a blog on that sometime in the next week or so, and am making my comment to Medicare about that. Other than that, everything's, a lot of the things that we've been concerned about have been modified or ameliorated by the, certainly by the pick your pace, and some relatively permanently, although we'll see what the next rule shows. And this rule, of course, goes into effect January 1st. It is, so first, ameliorating the misconceptions. It was rumored when MACRA was signed into the law that PQRS is over and meaningful use is over, but don't believe it. PQRS and meaningful use, the final submissions are due by March of 2017, just coming up around the corner. Penalties and incentives will pay out through 2018, but the programs aren't really over. They're being rebranded, reshuffled, redefined. The rules are being rebuilt, but frankly, the PQRS, or Physician Quality Reporting System, is the foundation for the MIPS quality performance category. So if you're used to doing the PQRS reporting, MIPS quality reporting is going to be very familiar. All the same mechanisms. I'm not going to say the same measures, because measures have been evolving every year anyway. That evolution continues under MIPS. But we're really starting with the same measure set, and we're taking that usual evolution with the specifications changing, some measures being retired, others being added. That continues in MIPS. Likewise, the EHR incentive program, everything you've come to know and loathe about that program. Well, that's not exactly true. I was going to say it continues. Frankly, that's changed favorably. It's dramatically easier. I think that the reporting requirements are easier, that you don't track an individual clinician anymore in this program. It really is specific reporting to the practice that the clinician is in, which makes it dramatically easier. There are fewer measures you have to respond to, fewer requirements. It's easier to prove that you have an EHR in place. So overall, I think this is very good. And if you are familiar with meaningful use reporting, you'll take very naturally to the advancing care information category under MIPS. So again, don't think these programs are over. They're just being reblended, rebranded, and reintroduced in the MIPS program. Oh, and let's also remind you that Medicaid meaningful use is unchanged and still in effect. This doesn't affect that at all. There's no longer a connection. I think in Medicare meaningful use, there was some interaction between the two programs. That's over. You can no longer get credit for advancing care information in the new program by doing your Medicaid meaningful use. You have to report independently. Then back in September, Acting Administrator Slavitt announced the Pick Your Pace program in MIPS MACRA, and I heard all over the place that MIPS has been postponed, but it has not been. MIPS is going in place as scheduled January 1st. It is watered down. It's much easier than it had been anticipated. I think what's happened then for 2017 is there's really no excuse for anyone to be penalized. They've made it so easy to avoid the penalty. They're calling it a year of transition, iterative learning and development. It builds ultimately to the same crescendo. The final year is exactly the way it had been. The final year that's mapped out so far is exactly the way it had planned to be, but it does have a kinder, gentler start. I will review some of the options for reporting that help to make it certain that you shouldn't get a negative adjustment. The timeline, this kind of illustrates, we've got these two programs, one that's disappearing, the PQRS and meaningful use programs, and one that's ramping up. And you'll see the old program I put in red hues and the new program in green hues. And this just illustrates that that multi-year facet of each of these programs. So we're in the 2016 performance year for PQRS and meaningful use. We're also in the payment year based on your 2014 performance. That was 2 years ago. In another couple of months, we're going to start submitting your 2016 data in that 2017 submission window. Then we'll start, and of course, January 1st starts your first MIPS performance year. And let's go to that. Next slide. This is just to pull out that this cluster of 3 years, just to make sure you get that down pat. There's a performance year. That's and here for PQRS, that was the 2016 performance year, which is reported in 2017. That's the second arrow, and that's paid in 2018 payment year. It's all based on that same reporting for 2016. And as we move into MIPS, of course, next year, your 2017, January through December, is your first MIPS performance year. We'll submit data for that in the first quarter of 2018, and the payment based on that performance year will be 2019. So this whole pattern continues inexorably year after year. That's that series of 3 years that interlock. And of course, and again, another illustration, those programs that you become used to on the left, the physician quality reporting system, the value-based modifier, quality tiering, which some of you are not even aware of because it's been kind of a stealth program slowly brought live, and then the Medicare EHR incentive program. These really aren't gone. They're being reblended and reintroduced there on the right as the quality payment program. Medicare just introduced the terms first pathway and second pathway. I'm calling those out simply. I think it helps to understand their perspective. First pathway, their emphasis, they're hungry to push us all to these alternative payment models, which introduces the terms APM type, APM entity, advanced APMs, qualifying participants, partial qualifying participants, split TIN, which didn't get much emphasis in the final rule. I'm not sure that has much importance. And then the second pathway, the merit-based incentive payment system, which introduces the concepts of eligible clinicians and virtual groups, amongst other things, and of course the 4 performance categories. Everything goes in place January 1st. Comments will be considered if they're received by December 19th at the regulations.gov. So get your comments in. Excuse me. Medicare, in the final rule, Medicare calls out this vision. It'll consolidate the components of 3 existing programs and continue the focus on quality, cost, and the use of EHR technology in a cohesive program that avoids redundancies. And again, I think they did a relatively good job of doing that. A lot of the confusion and clash of the old programs is gone in the new one. So I think this is a step ahead. Supporting the nation's progress toward a patient-centered healthcare system that delivers better care, smarter spending, healthier people, and healthier communities. This set of 3 slides, the last one and yet the next one, I'm particularly calling out as it will alert you to the reasons why we will see changes in the rules year to year. These are Medicare's goals, and as they watch the program and see how we respond to it as providers and vendors, we can expect the rules to evolve to get us closer to this vision. Including these 6 strategic objectives: improve beneficiary outcomes and engage patients, enhance the clinician experience through flexible and transparent programs, easy-to-use program tools, increase the availability and adoption of advanced APMs. And I think the fact that they're putting that as the first pathway really illustrates their emphasis on advanced APMs. And promote the program understanding and maximize participation through communication, education, outreach, and support, especially meeting the needs of the unique needs of small practices, and improve data and information sharing for accurate, timely feedback. I think that specifically speaks, we've been used to getting feedback reports and QR/UR reports from Medicare about the feedback report outlined our performance in PQRS. The QR/UR report outlined our performance in quality tiering and value-based modifier. That type of data will continue. The QR/UR is going to be reformatted, renamed, but as much of the data that we've been used to seeing in those will come through in whatever the new MIPS feedback report is going to be. And then finally, they state the bedrock of the quality payment program is high quality, patient-centered care, followed by useful feedback in a continuous cycle of improvement. Laudable if it can be achieved. Let's see. We'll wait and see. And 2017, of course, again, is considered the transition year, an iterative learning and development period. What a way to make lemonade out of those lemons. Characteristics of the transition year. First, we were alerted in the final rule that it could last as long as 2 years. In fact, it's already been scoped for 2 years with a phase-in of different weighting. They've already committed to the 2018 weighting of the performance categories. Pick your pace, certainly there for 2017. It's relatively silent on what's going to happen in 2018. Cost for the first year is weighted at 0 points, so we're not going to have to worry about that. We'll still see it in the feedback reports. We'll see how we're performing on cost, but we're not going to be graded on cost in this first year. Quality, the weight of quality is increased to 60 points for this first year. Those are slated to go down to cost to go up to 10 points and quality to 50 in the second year. Thresholds, I'll explain these thresholds in a future slide, and it'll tell you the thresholds determine why it's so easy to avoid penalties this year. And here are the pick your pace options. There are really 5 different possibilities for participation in MIPS MACRA or in the quality payment program in 2017. The first is all in, and all in is reporting on all the performance categories with the exception of cost for either a full year or at least 90 days. So a full participation is defined as only a 90-day reporting period for any of the performance categories. So you can choose to submit data, quality data for the whole year, or just pick a 90-day window to submit. Improvement activities need only be done for 90 days. Of course, that is a permanent, that's the permanent intention. 90 days has been defined since the beginning as the performance period for improvement activities. Meaningful use, we've always had that 90-day period in the first year of meaningful use and goes to a whole year. We expect that to go back to a year subsequently, but again, choose your 90-day period. For each of the quality performance, each of the performance categories, you can choose different 90-day periods for each of your reports. And by putting in those 3 reports, you're eligible for the full positive adjustment and the exceptional performance bonus, which we'll go over in a slide later. Then there's the sum data. And again, you're reporting for a minimum 90-day period. You do more than one quality measure or more than one improvement activity or more than the required measures in the ACI, the base measures, and you can qualify for some incentive and not the full incentive. And we'll look at that in that future slide. And then the caveat, this is the big thing, one single measure. You do anything, and you should avoid the penalty. This harkens back, if anyone remembers, in the 2013 submission year, we had the option, if you submitted one measure on one patient, you avoided the penalty. That was the very first penalty year for PQRS, and that seems to be resurrected now for this transition year. Medicare was relatively silent on that in 2013. They never acknowledged that it was a single measure on a single patient. They didn't want us to take that easy way out, and they seem to be doing the same thing here. But that's the way it reads, that there is no minimum data standard, and a single measure on a single patient should be enough to avoid the penalty. And then, of course, participating in an advanced APM is enough to avoid the penalty, and then of course the final choice is to do absolutely nothing. And if you do nothing, then you will get hit with a full 4% negative adjustment. So the all-in requirements, if you are all in for at least that 90-day reporting periods for quality measures, in PQRS, we're required to do 9 measures in 3 domains. Now it's 6 measures. There are no domains. They're looking for a single, well, we'll get to the data completeness criteria in another slide. But the 6 quality measures, advancing care information, there's 5 required measures in the base score, plus you can choose whatever other measures you want to get a higher score. Clinical practice improvement activities, which they might be shortening to just practice improvement activities. Although, do we really want to abbreviate that at PIA? We'll see. And they've reduced the requirement of that from 6 to 4 activities with a maximum possible score of 40 instead of 60. And there's no cost or resource use in year 1. Got a couple of questions. Let me look at that. Yvette asks, did you say you can choose different 90-day reporting periods per quality measure? No, I think all your quality measures will need to be the same 90-day period as far as I can see. It's that you can report a different 90 days for quality, a different 90 days for advancing care information, the new meaningful use, and a different 90 days for your practice improvement activities. And let's see, from Tracy, pick your pace, 90 or 1 year. Not following why folks would not just do 90 days. This is unclear. For pick your pace versus all in, are they the same? What they're saying is that a minimum data is that a mandatory data set for 2017 is 90 days. You can restrict your data to just that 90 days or give the full year. It is going to be somewhat of a PIA to do a 90-day data set, at least to give you the maximum benefit of that. So we'll be working on our algorithms to compare your performance for various 90-day periods and decide which one might be the best to submit. I would think for most of you, the difference between any particular 90-day cycle is negligible. But if you change your procedures early or sometime during the year, if there's a reason why your performance should be better in a different 90-day period, then you could have substantially different performance by choosing a different 90-day period. So again, the standard year-to-year is a full 1-year data set, and Medicare encourages you to do that. But all you need is a 90-day data set to be all in for 2017. And now from Carol, I have, do you think there are any advantages to report for more than 90 days? No, probably not. Well, it depends on the size of your practice. Most practices have enough volume that there should be very little statistical drift between any 90-day period. So by including the full year, you shouldn't add any more accuracy to your reporting. If you have low numbers, if you have low numbers, a low number of Medicare patients, to avoid outliers and some possible inaccuracy in the data because of that poor statistical correlation, you might want that full data set. I guess that would be the only reason to do it. There may be an advantage to particularly if you have good performance. One thing that will happen in a new program, if you have fewer than 20 patients in any particular measure, they'll accept it, but they won't score it, which means that they'll just drop the measure out of your average. It won't be scored 0, just won't be scored at all. and you won't get the benefit of your high performance. So a full year. So if you have only 10 patients in a 90-day data set and can get 20 by going to a full year, that would give you credit for it. So, all right. So let's. All right, moving on. The MIPS eligible clinicians. So about half of clinicians are being dropped from the MIPS eligible roles from PQRS. There's 1.3 million providers eligible for PQRS, which includes everyone on the right side here as well as on the left. But for the first 2 years of MIPS, it's only those on the left side of the screen. Physicians with this definition of physicians: doctors of medicine, osteopathy, dental surgery, dental medicine, pediatric medicine, optometry, and chiropractic. Also, physician assistants, nurse practitioners, clinical nurse specialists, and certified nurse anesthetists. All the rest on the right are dropped in these first 2 years. The Secretary of Health and Human Services has the discretion to add them back in after the second year. That doesn't have to, but my reading of the rules seems to suggest that the plan is to bring them back in. And whether it is in the third year or the fourth year, I think is anybody's guess. I'd be surprised if it goes beyond the fourth year before they get added back in. And then in and out, independent testing facilities are out. And I guess one caveat there, if the testing facility is creating a combined bill, is charging for the technical and professional services without identifying it to an NPI, they're out. If there's an independent professional fee associated with reading an X-ray or interpreting a result, then that, to the extent that that's beyond the independent testing facility, those charges are included. Then critical access hospitals, FQHCs, and RHCs are in for their Part B billing, at least those professionals we listed in the last slide. Now, there are some clinicians who are excluded from MIPS or have altered responsibilities. First, newly Medicare enrolled eligible clinicians. The first year of enrollment, first year in any practice, they are excluded from MIPS, and they come in the very next year. Anyone who's a qualifying participant in an alternative payment model, they are excluded. Excuse me, and that's an advanced, excuse me, this should say a qualifying advanced APM participant. The garden variety APM that doesn't have a downside financial risk, those are still MIPS included. And of course, partial QPs, they can choose to be in MIPS or not. And there's also a low volume threshold that's been strengthened a bit to your favor. That is, if an individual or group has either less than or equal to $30,000 in allowable charges, or less than 100 unique Medicare beneficiaries, then they're in the low volume threshold, and Medicare thinks that about 32% of clinicians will fall under that exclusion. And they'll be measuring that in the year prior to your MIPS, during the performance year. So 2017, they'll close that measurement by August 31st and publish by the end of the year who is in the low volume threshold. And you will not have to report if you're in the low volume threshold. In fact, there's two, they call it the low volume threshold determination period. And there's two periods for the 2017. One of them started last September, and it ran through this past August 31st with a 60-day run out to get claims for that period. So they'll determine your volume for that period, And if you qualify, you're out for the 2017 performance period. If you don't qualify, they're going to check again starting. You're already being measured now. That measurement will end August 31st, and you have a second chance to qualify for the low volume threshold. And if you qualify in either period, you're out. And that will keep running. So every year, the 2 years ago and the year, if you qualify under either year, you will be out for the next year. Then there's non-patient facing MIPS eligible clinicians. This is defined now as individuals with less than or equal to 100 patient-facing encounters. Now that's a wide variety of E&M codes and procedure codes. There'll be a full list of them out in the near future. So if you have fewer than 100 of those, then you'll have different requirements under MIPS. It's not that they're gone, it's going to be amended. Medicare estimates that 25% of MIPS eligible clinicians will be non-patient facing. Most pathologists, anesthesiologists, nuclear medicine, and diagnostic radiology providers. Telehealth services are now considered patient facing, so all those E&M codes or billing codes related to telehealth will be considered patient facing. There's also a non-patient facing determination period that looks just like that low volume determination period. If you're non-patient facing in either of the years, you'll be non-patient facing until that changes for 2 years in a row. And what that does is amend your requirements under quality reporting and under practice improvement activities. You have fewer practice improvement activity requirements if you're not patient facing. Now, composite performance score. Again, unlike the old programs, which each independently had you passing and failing in each of these areas, with the composite performance score, they add everything together with different weights, and you're scored on that combined weight. For the 2017 performance year coming up, quality is 60, cost is 0, clinical practice improvement activities are 15, and advancing care information 25. Now those last two stay stable throughout the life of the program. Quality is scheduled to go from 60 to 50 to 30, and cost from 0 to 10 to 30, and then it'll cruise along. The intent is for it to cruise at 30, 15, 25 for years to come. With some modifications depending on your circumstances. Under APM, you're not going to be responsible for quality or cost, so those scores will be reassigned to CPIA and ACI, and there's other circumstances. People particularly in the first year, people who weren't subject to meaningful use in the past, that was the non-physicians. They'll only be scored on advancing care information if they make a submission. If they don't make a submission, they're not scored, and those points will be reassigned elsewhere. All right, a quick look at the quality performance category. So that's requiring, let's see if I'm missing any questions here. Yes, Kathy asks, when you say fewer than 20 patients, do you mean only straight Medicare patients? Is that does not include Medicare Advantage patients? Actually, Medicare, good question. When you make a submission, one measure has to include one Medicare patient. But the submission requirements have changed from Medicare alone to all payers, and I'm assuming that all payers means Medicare Advantage as well. Um, I didn't see that called out specifically, but it seems to only make sense that an all-payer data set includes Medicare Advantages. So any measure with fewer than 20 eligible instances across all payers will not be scored. All right, so let's see. Back to the quality report performance category. 6 measures requirement, 1 outcome measure, or if there's no outcome, an intermediate outcome, or if there's no intermediate outcome, a high priority measure. And there's a list of those. I don't plan to get into that detail today. There's a 50% reporting rate required with an all payers data set. We expect they had planned to make it a 90% reporting rate, and I'm expecting that to go up to be phased in over a couple of years. I believe the current suggestion is that it hit 80% in year 2 and then 90% in the 3rd year. There were 3 administrative claims that Medicare calculated, all-cause readmissions, acute admissions that are ambulatory care sensitive, and chronic admissions that are ambulatory care sensitive. They've gotten rid of those latter 2 and only retaining the all-cause readmissions. Only if the group size has more than 15 physicians or providers, and there's at least 200 attributed hospitalizations to the group. If you don't hit those, then you're not going to be hit with the administrative claims measure on all-cause readmissions. Data completeness threshold. So what makes a data set complete? Oh, actually it goes from 50% to 60% from 2017 to 2018. Claims, still just Medicare Part B. Web interface, still Medicare Part B, but qualified registry, QCDR, EHR, and DSV all require all payers. There's still for the web interface, a 248 patient set is required. For all the others, 50% of the eligible instances are required, goes up to 60% in the 2nd year, and possibly as high as 90%, but they haven't mapped that out yet for the 3rd year. For 2017, we're expecting only a 90-day requirement for reporting. I'm expecting that to go to the whole year for 2018, but again, that has not yet been set in rules. There are bonus points for quality measures, so you can get 2 extra points for providing an extra outcome or patient experience measure. You can get 1 point for any other high priority measure, whether it's in substitution or in addition to the measures you plan to submit. Bonus points are capped at 10% of the denominator, so if you have 6 measures in your denominator, the total points is 60, and therefore the total bonus points is 6. There's also electronic submission bonus points. If you have end-to-end electronic reporting, you get 1 bonus point for each measure that you do that way. Again, capped at 10% of the denominator. The clinical data must be documented in certified health and information technology. The processing must not include abstraction or pre-aggregation. Our standard processes are already eligible for that electronic submission bonus, at least at the exchange of flat files and our internal processes to process those data to run the algorithms. But if you abstract charts, that negates that. And it takes away the big advantage of the EHR submission or the data submission vendor submission, that as an EHR, DSV, qualified registry, qualified clinical data registry, or web interface, any of those can have an end-to-end electronic reporting bonus. And this is what it needs to look like. This is the instructions that Medicare gives in the final rule. A submission would be awarded bonus for end-to-end reporting if the submission included uploading an electronic file without modification. That's really the gold standard. If you manually correct it, it's no longer an end-to-end electronic submission. It's to preserve the electronic flow of data and provide a verifiable method to ensure that manual abstraction, manual calculation, or subsequent manual correction or manipulation using abstraction did not occur. Now we can change the algorithms, we can alter them, we can change the translations as long as it's in an automated fashion. But we cannot abstract or correct the data once it's extracted. If there are too few measures in the old system, in PQRS, this is an enormous advantage of the new system. In PQRS, if you didn't get enough measures, you failed your whole submission and you lost everything. In the new system, you're missing measures just to get a score of 0, get averaged in with the rest, and you still get credit for everything else. There isn't a measure applicability validation test for the 2017 submission year, but it looks like there's something similar to that that's in development for 2018. So those of you who are having trouble finding enough measures when we get out of the pick your pace year, there still may be. I'm expecting to see some protection for you. There is an interesting new approach to the specialty measure sets. Medicare is publishing specialty measures, a measure set for every specialty and not every, for select specialties and subspecialties. And as long as you choose one of those, you don't need to go outside of that measure set. So if there's only 4 measures, that's all you need to submit to have a full complement. Most have 6 or more measures, so they could be problematic, particularly if some of them are difficult to measure, but I'd certainly start there. And again, you're not scored. You get credit for successful submission, but it doesn't get scored if there's fewer than 20 patients in the denominator. Topped-out measures, that is measures that almost everyone does extraordinarily well in. They're not taking these away. They initially proposed to do so, but realize that a lot of people will have harder time finding appropriate measures if they take those away. So what they're going to do is reduce the total score that you can get from that. So you'll get a demerit in essence, but still be able to use it. So there will be some strategy around deciding whether to submit a topped-out measure or whether to go after something that isn't topped out, but of course those are harder to get higher scores in. So it may be a toss-up which one you'll do better with. So there's, in that transition year, there's 2 types of measures you might submit. Class 1 measure is a measure that meets all the completeness criteria. And it can be scored based on performance. It has at least 20 cases. It has a benchmark. It has a date. It meets the data completeness criteria, and you can receive at least 3 points for any of those measures, and can receive as many as 10 points if it's doing well. And of course that pulls you up the adjustment scale. A Class 2 measure, it fails some of those, 1 or more of those requirements, and you'll get 3 points for those measures, and you can't earn anything more than 3 points. But 3 points is enough to avoid the penalty. Then there's resource use. Again, they're intending in the second year to bring total per capita costs that we're used to from the quality tiering program, Medicare spending per beneficiary. Those intend to come back. They don't plan to reintroduce the disease-specific cost of care measures except within episodes of care. They're tracking right now about 40 different episode cost groupers. They anticipate bringing 10 live in the 2018 year and more yearly after that. And you can already see those episodes of care, the cost for those being tracked in your supplemental QR/UR report, and they'll continue to provide tracking for those, both those that will be live and those that may come live in years to come. We already covered this transition year cost policy, 0 for cost in the first year and 10 points for cost in the second. Clinical practice improvement activities, patient-centered medical home. If you have certification from a national certification body, that's all the maximum possible points of 40. If you're participating in an APM, and I believe that's an advanced or a garden variety APM, you get 50% of your maximum possible points. Then there's high-weighted and medium-weighted activities. High-weighted are each worth half of your possible points, medium a quarter of the possible points at 10, and you need the maximum you can score is 40. Again, 90 days are required, and it's for group practices. Again, there's lots of things that build in benefits to that group practice reporting, and group practice reporting is encouraged in a lot of ways. In the new program, lots of advantages to it. One is that if a single provider is doing an improvement activity, you get credit for it with a 90-day required participation for that one provider. If one practice in a large multi-specialty group, multi-site, if one practice location is patient-centered medical home, everybody gets credit for it. Special populations points are doubled. You don't need as many improvement activities if you're a practice with fewer than 16 providers. If you're a rural practice, if you're in a health manpower shortage area, if you're a non-patient facing eligible clinician, any of those need half that number of points, or you double the point, half the number of activities to get full credit for improvement activities. Then there's advancing care information. There's 2 different ways of getting advancing care information score. If you're using the 2015 certified technology, this is the approach. There's both the required in green, and required is a very low benchmark. All you need to do is measure and show a non-zero performance rate that's been done once. It is essentially saying, I've installed it and it has these basic capabilities. And you get half of your points for ACI. That's 12.5 points for that baseline capability. Then you can choose any of the specific measures, any or all, to get a higher performance level, and up to 10% of your points on any one of those other measures. And they're listed here. You provide a numerator and denominator. Again, if it's non-zero, you get your required points, and then for anything above 0, you get your extra points. If you're on the 2014 edition, it's a slightly different approach. And of course, remember that 2014 edition is only going to be applicable in the 2017 year. When you go to 2018, everybody is expected to be on 2015 certified technology. And this drops your base requirement to 4 measures, and there's fewer optional measures, and a couple of them have been weighted up to 20% to give you a higher potential score. There's more than 100 points, more than 100% possible, so it should be relatively easy to drive your scores up. And again, getting 100 points in the scoring gives you the full 25 weight that goes into your composite performance score. There are bonus points available by doing extra registry reporting. You can get another 5%, and there's many improvement activities that are eligible for CPIA that are eligible for up to 10% bonus. So you can get an extra 15% using those combined methods. You don't have to do ACI if you weren't in meaningful use in years past. If you do submit, you'll be scored, but if you don't submit, your points will be distributed elsewhere. There are hardship exclusions if there's insufficient internet, if there's extreme or uncontrollable circumstances like the dog ate my EMR, a lack of control over availability or lack of face-to-face patient interaction, so that face-to-face measurement affects whether or not you're held to the ACI. And then advanced APMs. Interesting that advanced APMs brings all the other clinicians that were eligible for PQRS are eligible for APM. So even though the therapists and psychologists and nutritionists in the first 2 years are not going to be subject to MIPS, you still can get the 5% incentive for APM participation, as can critical access hospitals, federal qualified health centers, and rural health centers. And now a couple of the, just to be concrete about the difference between an alternative payment model and an advanced alternative payment model. The classic alternative payment model is Medicare Shared Savings Program Track 1. It's got an upside risk. You get extra profit if you save money, but there's minimal downside risk. You don't lose or don't lose enough if you don't end up saving money. You can still earn 50% of your points for practice improvement activities by participating in an alternative payment model. And there are special reporting considerations that the ACO report, quality report, satisfies your MIPS reporting. Your clinical practice improvement activities are built into the program or automatically considered, and so forth. In the advanced APM, you're an advanced APM if there's both upside gains and downside losses. You're at financial risk. You are eligible for the 5% incentive, whereas you aren't in the garden variety APM. And then after the first 5 years, with each new physician fee schedule, there's a favorable conversion rate applied to people in advanced APMs. They also earn 50% of the CPIA score and get those same special reporting considerations. It's a quality report, covers both, whether you end up being a qualified participant or not. And we'll cover that more in the future webinar about APMs specifically. Medicare is planning a more rapid expansion of options and trying to build more aggressive goals, and they've built a lot of new benefits into that program, so I think you may find it attractive, although the one thing you should be aware of is that the advanced APMs come with downside risk, so you need to be sure you're ready to take on that risk. How does it all fit together? This was the initial plan. And I bring this up because you'll expect to see this curve reappear after the transition year. So what we have is is a composite performance score here, which determines your adjustment factor. Now I think they're changing the terminology from composite performance score to final score, but we'll just stay a little bit loose on that while we let this language sort itself out. So if I get a composite performance score, that's a sum of all those performance scores. That's 70. I've tracked this up here. I can bring it over here, and I learned that my adjustment factor is 2%. And of course, this scale changes year to year, and this hasn't changed with the adjustment in this transition year. It goes from 4 to 5 to 7 to plus or minus 9% in this schedule. And it was initially, this has changed, the building of the composite performance score, but we still expect to see this kind of graph come back. And what's happening here is that those who are in the losing range down here, a negative adjustment factor, they're contributing to the pool, and it's required by law to be revenue neutral. So that money that's collected here on the adjustment side, the 60th percentile down is distributed to those on the winning side. This the 60th percentile up. And then Medicare's also throwing an additional $500 million into this additional adjustment factor pool to give extra incentive to those who are on the winning side. Now, here's what it actually looks like in this year of the transition program. If you hit this 3% or the third percentile minimum, there's no negative adjustment. If you don't do anything, then you fall off this cliff and you get a 4% negative adjustment. And then you just have this straight line curve from 3 to 100 that they divide whatever monies they collect down here to these, and they still have that $500 million they're distributing to the people with scores 70th percentile and above. So again, submitting a single measure on a single patient will put you right here. But and here's so we're distributing this money collected from the losers to these winners, and it's expected to be 199 million instead of the original expected 833 million, plus this extra 500 million in the pot up here for the exceptional performers. And I think we'll save this for a future future discussion. Physician compare and hospital compare will continue to be populated and enhanced in the new program. And what is the pathway to success in this final 2 minutes? So I think that what you need to remember in this new program is you're competing with everyone else in the nation for top dollar, and performance matters. So you need to invest in measures that you care about. If you try to submit measures that you don't care about, you're not going to perform well, and it doesn't make sense to invest time and energy in things that don't matter to you or your patients. You should also have extra measures in the hopper. In PQRS, there wasn't any advantage to submitting more than 9 measures. In fact, if you submitted your 9 best measures, you got your best score, and of course the 10th measure, which doesn't have as good a score as the rest, is going to pull your average down. But in MIPS, you're only going to be scored on the 6 top performing measures that you submit, and others that you submit will cue you for an improvement bonus in future years. So there will be an advantage to submitting others, and you should also have some that you're developing and you're improving the performance on. So every year you can take a look at all the measures you're considering and choose the 6 that are going to perform best for you. And know that everyone else in the nation is doing the same thing. So something that's performing well for you this year may not perform as well next year if the whole program has brought everyone up to some extent. So understand and improve that data value stream, that you're providing the care, that you're documenting the way it can be recovered, that you're extracting it, you can translate it, and you submit it accurately. That's the whole stream, and we'll be wanting to look at that stream over time and make sure we're optimizing every piece of that. And then you're also going to need to contain costs and understand that the data is not readily available to track those costs over time, but still understanding that cost value stream will put you in the best position to perform well there. And we're introducing our Muse Collaborative, which is a data-oriented approach to continuous learning. And these are some of the activities that will happen in that. And since we're out of time, I'm not going to get into that. And we're bringing live to you a full set of services to help each one of our clients to rise to the top of that payment ladder. So thank you very much for your time and patience. We're out of time now, but as usual, we will linger as long as there's questions being asked. And keep your eye open for our future webinars where I'll dig into the details of each of the payment category or the performance categories. Stacy asks, clarifying the 100 unique patients threshold, is it over 90 days or over the year if you opt for the 90-day reporting? That is actually over the year. And again, you have two opportunities to hit that. We've already passed the first opportunity, which was September 1st, August 31st, and we're in the midst of the second, which started this past September 1st and will end this next August 31st. So if you have fewer than 100 patients in either of those buckets, or less than $30,000 in charges, you will hit the low volume threshold. Nadia asks, for non-patient facing clinicians, so we have a group of half GIs and half anesthesiologists. Since these anesthesiologists are non-patient facing and can't report on advancing care information, does that mean that they also don't have to report on any of the other categories like quality and can be exempt from the entire program, and the other GIs won't be penalized as part of the group? Not exactly, Nadia. The non-patient facing clinicians don't need to report on advancing care information. They can, and if they report on it, they will be scored and they can earn, but they don't have to. They're still responsible for quality reporting, so they're still going to be looking for measures that they can submit for quality. They've got half of the load for advancing care information, so not completely off the hook. And of course, submitting as a group, you may find it convenient to whatever extent the GIs are doing well, the anesthesiologists will do well as well. I've always been recommending the group practice reporting option, and it remains a very solid option in MIPS MACRA, and in fact a much better option than it had been before. Let's see, from Stace, no, got that one already. From Carmel, what date in the year qualifies someone as a newly Medicare enrolled eligible clinician? Any date. So in the first year that any clinician joins the Medicare rolls in PICOS, the first time they're in PICOS is their first year in Medicare, and they are exempt from reporting for that year, whether it's January 1st or December 31st, and they are responsible the next year when they've already had part of a year under their belts. Let's see, I have Eric says, you're saying no reason to report longer than 90-day period. According to CMS, it says for a 90-day period you could get a neutral small payment adjustment. If you report for a full year, you could get a moderate payment adjustment. So wouldn't you want to do a year? Well, this may, maybe there will be more clarity when they convert the final rule into provider-facing documents, but my reading of the final rule is you get the same clout from a 90-day report as from a 365-day report. There is some confusion in their language that a partial report that doesn't include all the elements can't hit the full, can't earn the full incentive. But a 90-day report covering all of the performance categories, or excuse me, a 90-day report for each of the performance categories is slightly different. We won't go into why that's different. Can qualify you for the full incentive. Now, again, their final interpretation could be slightly different, but this is how I read the rule. Kevin, what is the difference between a Class 1 measure and Class 2 measure? A Class 1 measure meets all the completeness criteria. and qualifies you for the full potential 10 points. It's got a floor of 3 points. You're going if you submit any measure with whether it's complete or not, you'll get 3 points. If it's complete, it's a class 1 measure, and you'll get and you can get the maximum number of points if you qualify for that. A class 2 measure doesn't hit the 50% reporting requirements. It may not be all payers. It may not have a Medicare patient in it, but it's still acceptable to get the floor of 3, but it can't earn any more than 3 points. Maria asks, I seem to remember that CMS will establish benchmarks for measures without benchmarks during the performance year. Does this mean that existing measures without benchmarks will have benchmarks established after 2017, and 2017 reporting will be based on benchmarks and not receive the automatic 3 points, given all the other requirements are met? Oh boy, that's a lot of benchmarks. Essentially, you're right. There's a big change in Medicare's approach to benchmarks in the MIPS program. In PQRS, for a new measure, you were not scored. You were not compared to other practices on the new measures. It had to be in existence for a year. A benchmark had to be established before you got before quality tiering was taken into account. In MIPS, for new measures, they plan to score you on those. Anything that's been in existence for more than a year will have a benchmark that's published based on last year's data, and will be able to predict how you're doing in that measure when we submit it. For new measures that don't have benchmarks, they will establish a benchmark based on that year's data. So you can't know it until all the submissions are in and they compare everyone against each other. Now, for those, there will be a floor of 3 points. You can't lose. You can't get 0 points for those. So they'll establish that floor, but you still can't predict exactly how you're going to do until all the data is in. So those will be risky measures to submit, because you won't have that predictive ability to say, I'm going to be near the top of the heap. It could pull your scores down. Monique asks, PQRS QPP measured at the TIN level or the NPI level? Interesting question. In PQRS, you had the choice to do NPI level or TIN level, and you still have that choice, but it's going to be rolled up. It's going to be translated to the and delivered at the NPI level, and there's going to be some places where they pierce that NPI-TIN identity and actually pull in data from before. So as you change practices, and you left a performance year behind elsewhere, and you don't have a performance year for this practice for this payment year, they will bring your poor performance or your good performance from your previous practice forward into this one. And also, as particularly since not all providers are now MIPS eligible providers, when the group submits, they'll take those scores from the group, apply them to each of the eligible providers, and and those eligible providers will have the differential payment, and the non-eligible providers will not have their payment adjusted. So there's going to be some interesting tracking back and forth between the TIN and the NPI level and other data brought forward from previous practices. Looks like I've answered everything that's been pushed to me here. So how are we doing? Any other questions popping up? Okay. Yeah, I keep sending some questions. If there's people still on listening, I'm happy to answer questions. So Gay tells me there's a few more out there that she'll. They tend to be a little detailed, but if you've got patience, you might as well hang in and listen. Oh, here we go. Karen asks, will you suffice as a QCDR? If so, will you have specialty-specific options? Yes, we will be a QCDR. And my intention is and probably have specialty-specific options. My intention as a QCDR is to fill a special niche of having measures that cross specialty lines. And I think that's a particular hole. Many of the specialty-specific QCDRs out there kind of leave you in a uncertain what to do if you're in a multi-specialty group. It's hard to do GPRO reporting using any of the specialty-specific QCDRs. So my particular interest is in healthcare delivery and the measures that look at that healthcare delivery and the patient experience. And of course, the patient experience measures get special consideration and bonus points in the quality reporting. So I think this is a particular niche I'm going to try to fill. Of course, part of the intention of our QCDR is to help make sure that everybody has measures that are of meaning to them, and that will push us towards some specialty-specific measures, I'm certain. But that is a lower priority to me than the things that cross all practice lines and are meaningful to all patients in all practices. Deborah asks, if we're part of an ACO that is not yet part of an APM, and they're submitting the MIPS quality component on our behalf, how will our submitting the other components from MIPS work logistically without our taking a hit for the quality portion in our composite score? Also, will we need to attest as a group since we did so for the quality portion as part of the ACO? Yeah, I think this is one of the advantages of being an APM, whether it's an advanced or a garden variety APM. Your quality reporting for the ACO will cover your MIPS quality report. If you end up in the APM but not qualify as a qualifying participant, you don't have the volume qualification. The quality submission you did as under that ACO will cover your MIPS requirement. And let's see, cost, of course, no one has to submit cost that's calculated for all of us, so that's not going to make any difference. ACI, whether you're part of an APM or not, every tax ID number is going to, as an individual or as a tax ID, as a group, you're going to be responsible for the ACI reporting, and then that gets rolled up to the ACO level or the APM level. And the last, many of the APMs will have some built-in practice improvement activities. You'll get credit for those automatically, and if you don't get full credit, if there's not 100% of the points, you're permitted to submit additional attestations for other activities to bring that up to the full level. So it's an interesting set, and we'll go into that in more detail in the APM specific webinar. Rebecca asks, if you only have to report 50% of patients on the measure, is it possible to cherry pick which patients to include? Yes, it's possible. Medicare frowns on it. And that's certainly not the ethical high ground, but yes, it is possible to cherry pick your 50%. They've actually approved some techniques that aren't so much cherry picking, but are systematic. Like one of our clients asked about reporting only on those patients who have primary care visits and not those who only see a specialist. And that was approved as being systematic and not cherry picking. But again, you don't need the approval. They really don't have any rules against cherry picking. They just don't like it. Oh, April asks, how did you say the FQHCs are affected by these changes? Do they have the same reporting requirements? Yes, FQHCs have the same. Well, there's two ways they're affected. One, they are fully eligible to be part of an APM and get all the advantages of the alternative payment models. As far as PQRS goes, it really is no big change. Excuse me. As far as the MIPS program goes, it's not a big change over PQRS. They're still subject to the incentives and penalties to the extent that they have Medicare Part B charges, and only to that extent. So, and I understand that varies by FQHC. If all of your charges are cost-based reimbursement, you really have no exposure in MIPS. But if some of your charges are Medicare Part B off the physician fee schedule, then yes, that will be subject. And in many cases, it's not going to be enough to really concern you. The cost of responding might be more than you have to gain or lose. But for some, I understand it can be substantial. Where do we go to find out the results of the low volume threshold measurements? Asked Christy. I'm not entirely clear on that yet, whether you'll find that in your portal. I believe it will be in your portal. It might. I did see mention of the Physician Compare website. We'll know more, I think, when the user-facing documents come out from Medicare. What date in the year qualifies? Oh, I got that one already from Carmen. We will, Michelle asks, we will be excluded because we bill less than $30,000 per provider to Medicare. Can we still participate if we choose, or do we not have a choice? Actually, you might, in one sense, there is no choice. If you're below the low volume threshold, you cannot, I don't believe you can earn the incentive or be subject to the penalty. Now, you can get around that by submitting as a group, potentially, because if your cumulative group volume is above the low volume threshold, then you can, it's the same threshold whether you're submitting individually or as a group. So certainly there's some strategy around that. If you're going to be subject to a penalty, you might want to submit as an individual, so you're all below the low volume threshold. If you're subject to the incentive, you might want to submit as a group to make sure you get above the low volume threshold. Looks like I've got everything answered. Oh, so apparently one more in here. Let's see if I can. Oh, here it is from Nadia. For clinical practice improvement activities, 4 activities per provider or per group. The way we have reported in the past for meaningful use in PQRS is by individual NPI, but under the group TIN. Not sure if that's what you mean by group reporting. So I want to know how this would affect clinical practice improvement activities. So again, you get credit for everything by which way you choose to submit. If you choose to submit as as individual NPI, you have to submit everything as individuals. You don't have, it has to be the same across all 4 performance categories. So you're either group or you're individual across all 4. And it becomes it's always been easier to submit as a group. It's a lot less moving parts. And it's accentuated in this new program. One provider doing an improvement activity within the group is enough to give the whole group credit for that improvement activity. One practice being a patient-centered medical home is enough to give the whole group credit for patient-centered medical home. One being in an emergency response team or doing medical missionary work overseas is enough to give the whole group credit. So, and again, it depends on whether you're submitting as a group or individual. If you're submitting as individuals, each individual has to have something, has to fulfill the requirements. If you're submitting as a group, you just need to find collectively within the group someone who fulfills enough requirements to give you full points. Robert asks, what type of dollars are we talking about for the bonus points? And you can't really equate dollars to bonus points. At least I don't have enough data at the moment to equate it. We should be able to at some point in the analysis. But again, as you look at that graph that converts a composite performance score to an adjustment level, bonus points pull your score up by that number of points. I think, I'm just thinking mathematically, oh no, that's not exactly true. A bonus point applies to a performance category. So it increases your score within the category. But then there's that maximum score within the category gets converted to the weighted component in the composite performance score. So for instance, clinical practice improvement activities, you need 40 points is a maximum possible score, but it gets weighted at 15 in the composite score. So 40 CPIA points equates to 15 points in your composite score. So a bonus point pulling you from, let's say, 35 to 36 corresponds to a much lower increase in the composite performance score. And of course, every point you go up in the composite performance score equates to a higher adjustment level. So again, hard to, without more numbers, I can't tell you exactly what that equation is. And of course, in the there's a couple of moving parts in the quality reporting. you're getting scored on percentile levels, not just not just on the total score. I believe those points mathematically convert 1-to-1 on, but again, then and your maximum score changes depending on how many measures you have to you're required to submit, and how many have a full complement of at least 20 patients or 20 eligible instances. So again, the math is, I can't give you a hard and fast rule for that, but every bonus point does push you higher up that adjustment range. Pardon? All right. Well, I think I'm going to call it a day. Great questions. Thank you very much. Thank you for your attentiveness. I'll look forward to the next one. Our next presentation, I can't tell you what the date is. Charles will distribute that date, but I expect it to be the quality reporting performance, the quality performance category, sometime in the next couple of weeks. So thank you very much. You've been very kind. And time to get back to work. Ta-ta for now.